The purpose of this video will be to do a recap that's discussing the two patients that you had for your discussion this week. Natalee, who's a child, 11 years old, and then Alejandro, who is an adult. So for those of you whose last name fell in the range that you would be talking about Natalee, this is just a recap of what the instructions and the assignment gave you as far as information goes. So I've underlined kind of the points that I found to be important when I was looking at this. And so we know that we've been treating Natalee for about a year, so that means she came to us when she was probably 10 years old, and she's now 11 years old. And we've diagnosed her with depression, and originally when she came, she was having depression and irritability, and that was affecting her schoolwork and her school performance. So she's been taking Prozac 20 milligrams every day for the past 12 months. And we saw her 2 months ago, and at some point between 2 months ago and now when we are seeing her, we know that she started her period. Now, apparently since then, her mood has gone downhill, and she's been having trouble again at school and with her friends, and they're concerned that the med's not working in light of this hormonal change. You can see that there's a family history of depression, and we're asked what kind of screening tools would we use, what would we do with the medications, and then how would we educate the parent and the patient. So over the next couple of slides, we'll look at things that you want to be thinking about, and we'll look at some of the screening instruments and practice guidelines that'll kind of help inform our decision making for Natalee. So one thing I would want to know is, well, when did this all start? So we know that we saw her 2 months ago, and we know at some point her period started, but that's not to say that her symptoms started 2 months ago, right? And we don't know, have these symptoms been going on just a couple of days? Have they been going on for weeks? Have they been going on for months? So we'd want to kind of clarify when her symptoms began to worsen. We'd also want to know if there's any kind of a correlation between the start of her period and her symptoms. Now, of course, that's what her mom is concerned about, but when we're looking for a correlation, we're wanting to know, well, when exactly did your period start? And then when exactly did these mood symptoms start to worsen? Did they happen before the period started? If that's the case, then when your period started, did it get better? Because that might make us wonder if there could be a provisional diagnosis of premenstrual dysphoric disorder. Is it the other way around, where her mood was fine, then her period started, and then her mood symptoms started to decline? If that were the case, that would rule out premenstrual dysphoric disorder, because that's not how that condition goes. If it was, there was no clear correlating factor between when her period started and when her mood symptoms began, then that may or may not have anything to do with what's going on. The other thing we want to know is, well, what are these specific symptoms that are indicating to us that things have gotten worse? Because just saying my mood has gone downhill, or she's having trouble in school and with her friends, that really doesn't tell us anything at all, does it? I don't know that any of that information is specifically listed in the DSM as criteria for a major depressive episode. So, with just really vague and unhelpful descriptors like that, we're really not going to know what we're dealing with or what to do. So this is where screening tools or other instruments like the PHQ-9, which I saw many of you mention, can be helpful in narrowing down the specific symptoms that are going on, and that'll help us kind of have an idea of what to do on a medication standpoint. So while we are on the topic of screening instruments or self-rating scales for children and adolescents, the American Association of Child and Adolescent Psychiatry does have an updated clinical practice guideline for the identification and management of depression in children and adolescents. This is from 2022. And so this is just the snippet that talks about identification. So that would be screening tools, or you could even think of using this as symptom measurement. And I won't read all of this out to you, but this is just more of an FYI, and it kind of gives you a good overview of some of the tools that are out there, because there's lots of different ones. But again, to reiterate, what we're really trying to identify is, one, do the symptoms that Natalee has, which we don't know based on what's given to us in the discussion, so this would be something we'd want to ask, Are these symptoms that they're reporting or that they're concerned about? Do they meet the criteria for a major depressive episode? So when they say her mood's gone downhill, is this an indication to us that her symptoms are worsening as far as in the context of a major depressive episode? Maybe, maybe not. We want to know exactly what symptoms are going on. So you can see the criteria for a major depressive episode right here. And another way that we could kind of narrow that down, or at least as I like to call these a conversation starter, is to use something like the PHQ-9 or the PHQ-A, which was adapted for children and adolescents between the ages of 11 and 17. So that will have us narrowing down exactly what's going on, and then that will help us determine what to do with her meds, whether that be keep it as it is and consider recommending psychotherapy or counseling, or either increasing, switching, or adding something to what she's taking. So some other things we want to think about as we're having this follow-up appointment with Natalee is she actually taking the medication like she is supposed to? Just because you've been writing it to her for the last year does not mean she's been taking it for the last year. So that would be a very big question to figure out. Or it could be that over the summertime, her mom thought, well, maybe she doesn't need the medication. So there's that. The other thing we'd want to know is, has she had any side effects with the medication thus far that have been bothersome? Because that might have impacted whether or not she was compliant, and it also might impact whether or not going up on the dose is going to make sense for us to do that. And the last question you'd want to consider is, well, had this Prozac 20 milligrams that she'd been taking for the past 12 months or so, had it been helping otherwise up until the most recent relapse of symptoms within at least the last 2 months? That's good information for us to know, because if it otherwise had been working, then we might want to consider optimizing treatment before we completely try to reinvent the wheel. So just looking at some of the responses and sample prescriptions throughout the various sections, I took some screenshots of some of these prescriptions so we could talk about them. So one example that I saw is that many people decided that maybe increasing the medication is what would make sense. And that's a very reasonable thing to do. In my opinion, if she'd otherwise been tolerating it and there hadn't been problems, and if it otherwise had been working well for her up until that point, then instead of trying to change things up altogether, optimizing what she's currently taking would be the path of least resistance, and it would make the most sense to me. And so here, though, is where we have some problems, because you have to consult either the PDR or Stahl's Prescriber's Guide, or you could even look up the package insert for this information. But you have to know what dosages and what formulations does Prozac come in. So it might come in a tablet and it might come in a capsule, but it might not come in these various doses that you wrote for in either a tablet or a capsule. So like for prescription A, it says Prozac 30 milligrams, and it says 3 tabs by mouth daily. So the first problem that you're going to see here is that that's actually saying, from the way that it's written, that you're trying to give the patient 90 milligrams of Prozac, because it's implying that you're giving this patient a 30 milligram tablet of Prozac and you're instructing them to take 3 of them daily. And then you wrote it for number 30, so that's a 10-day supply. So one thing is that Prozac doesn't come in a 30 milligram dose. It only comes in 10, 20, 40, I think there might be a 60 milligram dose in a tablet form, but that's it. So there is no 30 milligram capsule. So already the pharmacy would not dispense it based on that alone. But then even if there hypothetically were, 90 milligrams of Prozac is typically higher than what you would usually write. 80 milligrams is more or less the max dose. Sometimes in OCD we might push it to 100, but 90 milligrams is definitely pretty high. And if she was taking 20, going from 20 to 90 is absolutely way too high and way too fast. So lesson here is that we have to check ourselves as far as what dosing and formulations the drug comes in. The same problem is what we're seeing in prescription labeled B. So the individual here wrote Prozac for 50 milligrams once daily in the morning, and they wrote it for 30 tablets. Well, for one, Prozac does not come in a 50 milligram strength, and it certainly doesn't come in a 50 milligram tablet. The tablets, I think, are 10, 20, and maybe 60. I would have to check that myself. So it does not come in that formulation or that dose. So the pharmacy would not be able to fill that prescription if it was written that way. Prescription labeled C, this one I think the pharmacy would probably accept. It's a little bit confusing because it says initially Prozac 30 milligrams, but then it clarifies and says take 3 of the 10 milligram tablets by mouth once a day for 30 days. And this individual had written the correct quantity and all that, but I wanted to eliminate any kind of identifying data. So probably the way I would have written this is I would have just said Prozac 10 milligrams, instructions take 3, caps or tabs, whichever one, take 3 tablets by mouth daily for a total of 30 milligrams per day. That's how I would have written it. But I think that this one would probably be accepted by the pharmacy because it's pretty clear what you're trying to say, and there's no issues as far as the formulation that it comes in or the way that it's written. It's just, I probably would have switched it and maybe not written the 30 milligrams up top. And prescription D is a perfectly fine prescription. This is for a Prozac 20 milligram tablet, and in this case it's saying take 1 tablet in the morning and then take a half a tablet in the evening. So this is interesting because if you remember from psychopharmacology, what did you learn about Prozac? Prozac has an extremely long half-life. So that means that it takes a minute for it to reach steady state, and then it also kind of self-tapers itself. So it's very forgiving if a dose is missed or if you need to abruptly stop it. So typically for drugs that have long half-lives, you really don't have to dose it more than once a day. And technically with Prozac, that's also true. But if you look in the package insert and also if you look in Stahl's Prescriber's Guide, it does mention that doses above 20 in children, you might want to consider dosing more than once a day. So why would we do that? There's a couple of reasons why you might want to think about dosing Prozac or maybe even other medications more than once a day. I'd say probably the number one reason why I might do that is if there's any tolerability issues. So sometimes if the person were to take, 30 milligrams all at once, they might have, nausea or feel sleepy or, whatever kind of side effects you want to list. And the issue is more so with them just taking it all at once. But if you were to split the dose up, then they might not have any problems as far as like tolerability is concerned. But there's no reason from at least like a metabolism standpoint, unless this person was like a rapid metabolizer perhaps, there wouldn't be really a good reason to split the dose up. And remember, sometimes Prozac can be mildly activating, so you'd have to consider whether or not that dose in the evening might mess with sleep or not. But prescription D is a perfectly fine way to write it. There's nothing wrong with it. It's just think about those things when you decide to do that. So let's look at these examples. So for prescription E, the provider's plan is to taper off of the Prozac and then to switch on to something like Zoloft. So they're going to go down to 10 milligrams for 1 month and then stop it altogether. And then they would start the Zoloft at 25 milligrams once a day. And so they also provided 2 refills. So here are some of the concerns I would voice about this plan. I don't inherently have any issue with the idea to switch the Prozac to the Zoloft. That wouldn't be my strategy. I would have optimized first, provided that Natalee was tolerating it okay, and up until the last 2 months when things seemed to get worse at some point, if the Prozac had otherwise been working, I would have optimized. Other reasons why I would have optimized, it's FDA approved for her age group to treat depression. It's the only one. And Zoloft is not FDA approved to treat depression in her age group. But let's say for some reason I was going to switch to the Zoloft. then um, one, I don't know that you would need to wait 4 weeks and then start the new one. There's really not a set in stone, 100% agreed upon way to do a medication switch. So some people stop one and then start the other. The fact that Prozac has such a long half-life, you technically could stop it altogether and then just start someone on the new drug, and the Prozac's going to taper itself. The other way you could do it is you could decrease the Prozac to the 10 milligrams and then start the Zoloft at maybe 12.5 milligrams and do those at the same time. And then after you stop the Prozac, you could increase the Zoloft to the 25 milligram dose. There's several ways that you could do that. But my first concern would be, well, if she's not doing well on 20 milligrams, why on earth would we decrease it to 10 milligrams and then wait a month before we start something new? Like, that seems like a very long time to be on an even lower and even more likely to be an adequate dose of something while she's doing poorly enough that she's checked in to make an appointment. So that's concern that I have there. The other thing I really would not recommend is if you're going to make that medication switch, I would not give her 2 refills, because based on the way this script is written now, if you're going to decrease the Prozac for a month and then she's going to start the Zoloft that second month, then technically we could possibly not see her again to make sure everything's going well for like 4 months. That's entirely too long to wait. On the next slide, you'll see that there are guidelines that we have based on the FDA's education that they supplied to parents and patients, family members, what have you, about children and young adults taking antidepressants. We have guidelines on how frequently we really should be seeing this population. And the short answer is it's not in 4 months. So we'll go over that on the next slide. For prescription F, this is another example of someone who elected to kind of switch the medication altogether. Now, it's not clear from the way that this script is written what their plan was to do with the Prozac, but that's not really a concern here. My first concern would be, one, Wellbutrin is not FDA approved to treat depression in children and adolescents. It does not mean that we don't use it sometimes to treat children and adolescents. But my recommendation to you is that you really want to have a really good rationale for why you would use something off-label and not approved for either the diagnosis or the age group when there are options out there that are FDA approved, either for the age group or for the diagnosis. So, like with prescription E, Zoloft isn't FDA approved to treat depression in her age group, but it is FDA approved to treat depression. And Zoloft is approved to use in her age group for a different diagnosis. So it's far less of a risk there than it would be to put her on, say, something like Trintellix, which is FDA approved to treat depression, but it's not FDA approved to treat any diagnosis in her age group. You see what I mean? So, Wellbutrin's not approved to treat depression or any diagnosis in her age group. That's the first thing. The second problem with this is, again, there is not a 37.5 milligram tablet of the immediate release Wellbutrin. So you really have to check these drug guides or the package insert, Stahl's Prescriber's Guide. You have to check that before you just start writing prescriptions, because the pharmacy would not accept this prescription. The other concern I'd have is it's written for twice a day. So you need to think about how feasible it would be for a patient to do this and be compliant. So Natalee's an 11-year-old girl. She's likely going to school, so then that means she'd have to probably take a dose of the Wellbutrin while she is at school on the days that she goes, because we're expecting Wellbutrin to be kind of activating. It's not something you want to give at night, or you might not want to risk giving it too late in the day after she gets home. So we're looking at morning time and then sometime around lunch. So that's going to be inconvenient for the patient, and it's going to require her to consistently go to the school nurse to get that prescription during those days. So that Doesn't mean that we couldn't do this. It just wouldn't be my ideal option if there are other more simple options that we could have explored. Um, Switching to something like Zoloft, switching to something like Lexapro, perhaps. You could maybe even consider something like Cymbalta. Um, but that would be my thinking. Is I don't know that I would want to complicate the regimen even further by having multiple times a day dosing. If it's possible that you could get away with a drug that's one time once a day, that might work well. And it's also FDA approved either for her age group or for a other diagnosis in her age group. So this highlights the frequency based on the FDA's medication guide about antidepressants in children and adolescents. And the frequency that's recommended by FDA is to have a total of 7 visits with their provider within the first 3 months of antidepressant drug therapy. That's whether we're initiating something or if we're starting them on something new or switching them to something new. So theoretically, you're supposed to see the child once a week for the first month, so that would be 4 times, then every 2 weeks for that second month, and then another visit at that 3-month follow-up. So I would not recommend at all ever writing refills on a brand new prescription for a child or adolescent, or really for any patient ever, until you've followed up with them and you are certain that they're on the right track, that their symptoms have stabilized, and that it makes sense to give them enough medication that they don't have to follow up until 3 months. If you want to see them regularly, then only give them enough medication to get them to their regularly scheduled appointment. So just as a reminder, as far as medications, quote unquote, antidepressant medications, we'll say, that are FDA approved to treat children and adolescents, this is a pretty good table from CMS that gives you a short and sweet kind of idea of what meds are approved for what disorder, so what indicated use are they approved for, what age range are they approved for, and then what's the initial dose and what's the max dose, and then other kind of things to think about. Fortunately, all of these are generic. So if you look at this table, you will see that Prozac is the only option that's FDA approved to treat major depressive disorder for Natalee's age group. She's 11 years old. Other medications are approved for her age group, but they're treating things like obsessive compulsive disorder. So that still would be an off-label use of those medications. So for those who opted to switch to Zoloft, just know you're switching someone in that age group to a medication that's off-label for that condition, major depressive disorder. So you can take a look at this here. And then UpToDate has a really good overview of the revised medication guide and the labeling regarding suicidality associated with antidepressants that you can see here. It also has some pretty good verbiage on the off-label use of these medications for children regarding like major depressive disorder and all that. So you can read this on your own, but I thought that would be useful information to include. And hopefully this would be information that you would include in your education to Trina and Natalee as you're talking about your medication decisions either way. So let's switch gears now and talk about those of you who had Alejandro. So I've underlined the parts that I thought were relevant to me as I was looking over his case. So we know that Alejandro is 34 years old, and he's a patient that we've been seeing at least for some point in time because he had previously been at our group therapy sessions, and you've also been treating him in individual therapy. So at some point you have diagnosed Alejandro with major depressive disorder, recurrent moderate, and in your treatment you've given him trazodone 50 milligrams at bedtime to help with sleep, Ativan 0.5 milligrams 3 times a day for anxiety and agitation, and then at some point he began taking Seroquel 100 milligrams and Lamictal 100 milligrams. So this past week he was admitted to the hospital for a third time for an attempted suicide. And he tried to overdose on about 100 tabs of Seroquel and 100 tabs of the lamictal, which resulted in him being in the ICU for a week until he was medically cleared. From what we know, based on the number of pills that he had, he likely was not taking his medications consistently and was possibly stockpiling them. So when you are seeing him, he's complaining of persistent depressive symptoms here. So we're looking at symptoms now. He's telling us that his sleep has been terrible, and it sounds like it's probably initial insomnia, because he's describing it as he lays there at night and his mind is just going. He can't shut it off. What is it going about? Well, he says that he's thinking about all the ways that he's failed his family, what a terrible father he is. So we would call this sort of negative ruminations, is what we would describe that thinking as. Along with that, he also doesn't really have any energy or desire to get out of bed in the morning. He's got feelings of worthlessness, and his insight's limited because he can't really give us a explanation or kind of walking us through, what happened that led to this third suicide attempt. We know that his physical exam and the lab results have been normal, and with that specifically, thyroid functioning and vitamin D levels are normal. We also know that family history, his mom has had an anxiety disorder, and he had a cousin that died by suicide about a year and a half ago. And he's married and has a 16-year-old son. So with Alejandro, we're asked again, what kind of screening tools would we use during this visit with him? And how do we feel about the diagnosis? Are there any symptoms that he's reported that would make us consider something different? If so, what evidence or what symptoms are we looking at that would make us consider whether we need to change his diagnosis or not? And then what would we do with his medications? And what kind of education would we provide to him about the medication? So some things to be thinking about as we're looking at Alejandro's case is, number one, are we sure about the diagnosis? As you were reading his case study info, what should have stood out to you as weird was the diagnosis of major depressive disorder, recurrent moderate, but then a medication regimen that doesn't really look like someone who's being treated for major depressive disorder. He's on 100 milligrams of Seroquel, 100 milligrams of Lamictal, and then 50 milligrams of Trazodone. So, of those, the Seroquel is the only one that's approved as an augmentation agent to other antidepressants for the treatment of major depressive disorder. Otherwise, everything else that he's taking, it appears that they're treating, or we were trying to treat, maybe bipolar type depression. Who knows? But the meds don't match the diagnosis, let's put it that way. So that should stand out as like a big red flag. Like, is it possible that a big reason why he isn't getting better is because we're not treating him with an effective regimen for the diagnosis that he has? The next thing we want to think about is, well, what's up with the compliance? Like, we know from the info we were given in the case study for our discussion that he overdosed on 100 pills of the Seroquel and 100 pills of the Lamictal. So then based on, having 200 extra pills, he clearly was not taking his regimen as prescribed. Now, that alone could be part of the reason why he hasn't been doing well. But then we need to consider, well, why wasn't he taking them? Was this part of like a long game plan that he intended to overdose, and so he was really stockpiling these meds? Or were there other reasons why he wasn't compliant? Which leads to the next question as far as, have there been any side effects that he's experienced from this regimen? Could be that he was having, sedation or weight gain or some other kind of problems related to that regimen, and that was why he wasn't taking them consistently. But to circle back kind of like we did with Natalee, we really want to be crystal clear about what kind of symptoms we are specifically trying to target. Now, unlike Natalee, we were given a bit more information as far as what he's experiencing and complaining of to kind of guide us, but obviously we're not given a ton of information. So again, as with Natalee, this is where additional information and using screening tools, which I saw many of you also refer to the PHQ-9, or there's the Hamilton Depression Inventory. There's lots of good ones out there. Any of those would be perfectly reasonable. But what we're really trying to do, again, is clarify what symptoms are going on, how long have they been going on, And do those symptoms all together add up to meet the criteria for a major depressive episode? And I want to remind you of this diagram. We talked about this back in psychopharmacology, but just to reiterate, we can look at the various symptoms of major depressive disorder, so the symptoms that constitute a major depressive episode, as you can see here, and we can hypothetically connect those symptoms to specific, brain areas, but for our purposes, we're looking at neurotransmitters that would have an influence on those symptoms. And I mean, particularly with mood disorders, our symptoms are typically going to fall into either reduced positive affect or increased negative affect. And the chemicals that are involved and the symptom domains that those neurotransmitters kind of influence will by and large affect the way that we go treatment-wise. You can see in this picture on the bottom right, looking at the various symptoms, we can connect them to drugs that affect, either norepinephrine, dopamine, or serotonin / GABA or histamine. So as I was looking at the various responses, there were really, I guess, two schools of thought as far as how to approach this. And one of the major schools of thought was, well, it looks like he needs to be on a medication that actually treats his diagnosis. Where is the evidence of him being on a first-line treatment like an SSRI or SNRI? So I saw many people suggest things like Lexapro or Prozac, or like in this example, someone suggested Effexor. All of those would be reasonable options. Additionally, Symbyax was another option that someone thought of, which would be a reasonable option because it is FDA approved for treatment-resistant major depressive disorder, or it's also approved to treat bipolar disorder in the depressed phase. So if you were really on the fence and could not decide whether you were treating bipolar type depression or if this was just treatment-resistant depression, the Symbyax would kind of cover you from both ends, I suppose. One thing to remember with Effexor is that at doses below, 200 milligrams or so, for all practical purposes, it is just an SSRI. It does not start having any of that norepinephrine activity until you get at much higher doses, like greater than 200. So for all practical reasons, it's basically the same thing as if you started the patient on Prozac or Lexapro when they're on a low dose of Effexor. But of course, we do have to start low and work our way up. An alternative to Effexor that I probably would have done if I were going to start the patient on an SNRI, if I was really wanting that norepinephrine activity, I would have started the patient on Pristiq instead of Effexor. Remember that Pristiq is a metabolite of Effexor. And one of the biggest differences is that it already starts working on norepinephrine at the starting dose. So you don't have to work your way up to a higher dose before you start getting that norepinephrine activity. It's already working on that receptor from the get-go. So that would be a big reason why I would choose it. It's also generic, so it's not really a cost issue at this point anymore. Back when it was brand name, that was a different story. The other school of thought that I've seen in the discussions was putting Alejandro on lithium. And the reasoning being, if you believed that he really has bipolar disorder, then lithium is a good option as far as mood stabilizing agents go for the treatment of bipolar disorder. And it's also a good option as far as having anti-suicidal qualities to it. It also is an option that is used for non-bipolar depression that has not responded, so you can think of it as like treatment resistance. Or if we're trying to specifically, use the anti-suicidal properties for someone who has non-bipolar depression but still struggles with chronic suicidal thoughts, adding lithium is a perfectly reasonable option. So looking at these prescriptions, there's just a couple of things that I'm thinking here. The first one, remember that lithium comes in two formulations. You've got an extended release formulation, and then you have like a non-extended release formulation. The biggest difference, I believe, is like the dosing options that are available. The extended release version of lithium, if I remember correctly, only comes in 300 and 450 milligrams, whereas the non extended release version of lithium comes in 150 and 300 milligrams. Um, a kind of misconception that a lot of people have, and I can see here that, at least in these examples, this is demonstrating that misconception, is that you have to dose lithium more than once a day. You absolutely do not, and it doesn't matter if it's the extended release or the non-extended release. The half-life of lithium is about 24 hours, whether it be the extended or non-extended release version. So there's really not a great reason to dose the lithium multiple times a day, unless it's for tolerability issues. And that's really what the extended release version is theoretically best suited for. It's a better tolerated option compared to the non-extended release version. But you do not have to dose a patient multiple times a day in either case. In fact, all the guidelines strongly recommend that it's just dosed all at once. So that's an important thing to know. The other thing to think about is whether or not we're using it to treat bipolar disorder or non-bipolar disorder. The efficacy of lithium is never based on the dose. It is always based on the serum level. I'm going to say that again. The dose of the lithium never determines its efficacy. Lithium's efficacy is always driven by its serum level. So remember that lithium has a very narrow therapeutic range. It's 0.6 to 1.2. Typically for bipolar disorder, we're needing it to be in that higher range. So we're like looking for like 1.0 or so if we're trying to treat like a manic episode. But according to the guidelines for treatment augmentation for non-bipolar disorder, you're looking for a targeted serum level of like 0.6 to 0.8. So it's on the lower end of that therapeutic range, basically. What ends up happening a lot of times, though, is low doses of lithium are added to someone who's on an antidepressant, and it's expected that just the low dose itself is somehow going to fix things. But again, the dosing never determines the efficacy of lithium. It is always based on the serum level. So a super low dose of lithium is never going to give you an adequate serum level, most likely, depending on other factors. So you really do need to check that level. So in these two examples, the biggest thing that I would have changed is one, I would not have dosed the extended release lithium more than once a day. I would have just done it all at bedtime. And similarly with the non-extended release version of lithium, I would not have dosed it 3 times a day. I would have dosed it just all at bedtime. But I probably would not have started a patient at 900 milligrams at that point. I probably would have started them at 300 milligrams and then, maybe increased it to 600 or so the following week or whatever, depending on tolerance. And then I would be checking a level pretty regularly until I got them to at least that 0.6 or 0.8 range if I were using this to treat non-bipolar type depression. But again, if we were using this to treat non-bipolar type depression, we still need to be adequately treating the mood disorder with a first-line option. We don't augment until we either have reached partial but not full remission. And so in the absence of a first-line treatment, it wouldn't make sense to just go straight to lithium unless we thought the diagnosis was no longer non-bipolar depression. If we thought it was bipolar depression, then yes, it would make sense to then perhaps start something like lithium. Though lithium's usually not the first-line treatment for a depressive episode in bipolar either. Think about that. So a big kind of overarching discussion we should have in both these cases of Natalee and Alejandro is, what do we do when the patient's either getting worse or they are not getting better? Well, the first thing we do is make sure there is not some other reason why this might be the case. So we're looking for medical problems like thyroid problems, anemia, vitamin deficiencies, long COVID maybe, anything that might mask or mimic the depressive symptoms. We're going to want to make sure that's either being addressed or that's been ruled out. We also want to make sure that there aren't or that we're accounting for any new or different medications that might be on board, because those could potentially have side effects that mask or mimic the symptoms that are going on. Or there could be drug-drug interactions that are either increasing the levels of what we have our patient on and causing side effects, or they might be decreasing the levels of the drugs and affecting the efficacy of our regimen. We also want to think about whether or not there's any substance use going on. Now think about Alejandro's case. It said that his physical exam and labs were all normal. Now, it didn't explicitly say that a urine drug screen was checked, but we can assume that if one was checked, that it otherwise was normal. But remember, a urine drug screen is just like a snapshot. It's like a photograph, a snapshot in time. So just because you have a normal urine drug screen, that does not mean your patient is not using substances. It just means that there wasn't any substance use detected on the urine sample during the time frame that substances would otherwise be detectable. And similarly, if you have a patient with a positive urine drug screen, that doesn't mean that they have a substance use disorder. It just means that the patient had used some kind of a substance that was detectable during the window of time that substances would be detected from that source, that specimen source. So we still want to evaluate for that, even if the labs suggest that that might not be part of the picture. And of course, compliance is always an important thing to evaluate for, and if a person is not compliant, it usually is a good idea to ask, well, why not? Why are you non-compliant? Is it because the drug's too expensive? Is it because it's causing side effects of some sort? Is it because they just don't have faith in it, or that it's not working, or whatever the reasons might be? Kind of asking that question really goes a long way. But once we've done our due diligence and kind of addressed those other things first, then our options really are to increase the drug, to switch the drug to something else, or to augment, or you might hear it called like adjunctive therapy, to add something to the regimen with a different mechanism of action. Here's kind of my suggestions for when to do what. If a medication regimen or, a drug on its own has otherwise been helpful up until the point that their symptoms worsened, if you've got wiggle room to increase it, that's the path of least resistance, provided that they've had no issues tolerating it. If they've had issues with tolerating it, which that kind of brings us to point number 2, then it might make sense to switch. So if a drug has not been helpful, and that's assuming that we have gotten to an adequate dose for an adequate amount of time, or there have been side effects that would limit optimization of that drug, then you probably ought to just switch it to something else. Because an inadequate dose of a drug will always do an inadequate job. It doesn't matter how much time you give it to do its thing. It's never going to do it at an inadequate dose. Remember that. So then if we don't want to switch and we're already at the max dose, and that's assuming that the patient has had a response, so the drug has helped, but you're at the max dose and there's nowhere to go up from there, then you might think about adding something to it that has a different mechanism of action versus switching it altogether. But if you're at the max dose and the drug has never helped, typically adding something to it does not magically make this drug start to work. If anything, if they have a response, it most likely is because of the new thing that was added and not because of the ineffective thing that they'd otherwise been taking. So you want to try to minimize polypharmacy unless it makes sense to keep adding things to it. But if it was not working, it's kind of like if your car was completely out of gas, changing the spark plugs doesn't make it start working, right? Or changing the oil does not make it start working. You can do all kinds of things to the maintenance of it, but if you don't actually fix the problem, it's really not fixing anything at all. And I thought I would include this last slide here that comes from the psychopharmacology algorithms from Harvard Medical School. this is based on, their review of the guidelines. There are lots of guidelines out there. So remember, algorithms are kind of like game plans. They're not the law. You don't have to hold yourself to these 100%, but they're generally pretty good evidence-based guidelines. So it certainly is a good starting point. So you can read this on your own, but generally speaking, you would start with an SSRI or an SNRI, and then depending on how that goes, you start either adding or switching. And then it might be worth considering treatments like ketamine, especially if we need kind of rapid stabilization of symptoms. So like in Alejandro's case, if we're still having this chronic suicidal ideation with or without a plan and severe major depressive symptoms, it might make sense to add something like Spravato, provided that he's already on some kind of antidepressant treatment. Spravato might be a very good option to think about. Electroconvulsive therapy or other kind of brain stimulating therapies like transcranial magnetic stimulation might also be a good thing to think about or consider in his case. Of those options, electroconvulsive therapy is the most effective of those, and it is kind of the gold standard as far as treatment resistance goes. But everything has its risks, of course, so that might be an option that he's not interested in or that he's concerned about. So then a much less invasive and also effective option could be something like transcranial magnetic stimulation.